we're going to talk about technology, but we're going to talk about the clinical impact. Some of those questions are important because if it doesn't save money, as Catherine talked about, if it doesn't improve for the care continuum of patients, it's not appropriate to bring these technologies in. We live in a funny place in California, specifically where I was born and raised in the Bay Area. We have a tremendous amount of medical technology, a tremendous amount of biotechnology, and a lot of IT. In fact, babies are learning about iPads and Google Glass before they are rattles and baseball bats. They're young, they're restless, and this movement this time is real. Back in the late 90s, there were a lot of tiny bubbles, most of which popped. Now there's bigger bubbles. They actually have revenue, for God's sake, before they go public. We're going to see Twitter go public here very soon. They just raised their price this morning, probably on the order of 12 to 15 billion. Facebook went out at 80. I think today at $50 a share, it's 120 billion. LinkedIn, Groupon, Zinc. Facebook at 120 is half of what Samsung and Johnson & Johnson is. So the combination of life science and IT is on its way, and it's on its way in the most fervor in this state of California. If we talk a little bit about healthcare, there is a curse going on. First of all, we spend more money than anybody around the world, and our life expectancy is 47th. That's slightly above Albania. We spend $20 billion on rehospitalization of Medicare patients, 26% of which get rehospitalized 30 days after they get discharged. And the fines that are coming out to hospitals for this travesty is mounting exponentially. We've also got a challenge in the MedTech industry. We've got a revenue tax, which is short of disgusting, because it actually taxes the small, innovative startups that are just beginning to come out with revenue. There's a huge wedge between academics and industry. You don't take the healthcare professions, you don't take the Catherines out of working with industry. That will make not only it go offshore, but that won't bring technology crisply to the patient's need and the bedside. 40% of the venture capitalists in the San Francisco Bay Area are out of life science, and probably 20% that are in today will be out in 3 years. And the healthcare process is changing minutely. Today, it's not about the best devices, it's about good enough. There has to be a cost sharing, there has to be a risk sharing, and there has to be a vertical integration, especially into emerging markets, which, by the way, occupy about 50% of the revenue of most of these life science companies. So everybody's getting depressed about this healthcare landscape. The VCs are decreasing. Why? Because the FDA has been onerous. Not just onerous, but unpredictable. It's hard to fund to ambiguity. The IPO market is actually getting better in the last 8 months for biotech, not necessarily medical technology. And M&As have averaged 39 for the last 5 years. So you can understand why the classic venture capitalists, who are used to the 90s, by the way, who take credit when it's going well, who point fingers when it's going badly, are tired and getting out. But so we're sitting here at the end of 2013, and I can tell you from traveling around the world and seeing not just the things in the Bay Area or San Diego, that the index of innovation is higher than I've ever seen it. The problem is the classic ways to get capital is not. So where are all the capital coming from to do these? Well, it's actually phenomenally new places. And people cannot go to the old lanes and look for capital. Microfunds are emerging like poppies in California. Strategics are making more early investments in the last 3 years than they have the last 30 years. Crowdfunding, 2 of my companies have crowdfunding. If you don't know what crowdfunding is, look it up on Google. It is a very interesting way to fund companies today. The young, high net worth individuals, from the Dorseys all the way to the Zuckerbergs, that are actually young, have young kids, and want to see healthcare continue, are coming out of the forest. Many of those young, high net worth philanthropists are investing in healthcare. Organizations such as Cleveland Clinic, GCIC, Coulter, SBIR has handed out more healthcare allotments in the last 2 years than they had the last 10. Large IT funds are coming into medicine like I've never seen it before. And by large, I just mean 100 million, not the billion-dollar IT funds. OUS venture capitalists are more active in Europe, Israel, and Asia than they've ever been before, and insurance companies are actually in early-stage funding. So don't complain about there's no money out there. There's plenty of money out there. You just have to look in different spots. I get the opportunity to promote, be involved in startups across the world, China, Tel Aviv, and in the Bay Area. And at least in the last 18 months, in that, we've had 12 approvals, CE mark, FDA, CFDA, that's China, TFDA, that's Taiwan, 7 M&As, 3 IPOs, and revenues that are 20 to 30% CAGRs. But they're not all in the Bay Area. They may be in Ireland. They may be in Shanghai. So globally, there is not a sore spot. You go up to Sand Hill Road and healthcare is a sore spot, but it's not globally. And I think that's an important issue to understand. At Stanford, we try to teach that global initiative. From the Stanford Biodesign program to the BioAsia program, identifying, as Catherine said, the needs at the bedside is the most important ingredient to come up with the concepts in order to solve what issues, and we have a ton of them, in healthcare. All the way from admission to rehab. All the way from Tel Aviv to Taipei. It's global, it's important, and in my estimate, it's moving like I've never seen it move. The combination of different talents like we have in this room, the screwdriver and the stethoscope. The little guy on the left started a company called Edwards down the street. The guy on the right is a tall surgeon that had hydraulic problems. Edwards was a hydraulic engineer. This promoted what started one of the most important feature sets in treating cardiovascular valve disease. But the landscape's changing. You cannot come up with a gizmo, a gadget anymore. You used to be in the 90s, and I was part of that whole phase where you could come up with a gizmo or a gadget and transition it pretty easily. Venture capitalists love that. We kind of liked it, but forget that. You have to be thinking about how this gizmo or gazmo is going to not only save direct money, but indirect money, how it's going to improve patient care, like Catherine says, how it's going to decrease blood transfusions, how is it going to increase people from not coming to the hospital, how is it going to decrease their complications once they're in the hospital. So let's talk about a couple of these. So reduce hospital stays, reduce complications in the hospital. We've been part of an initiative in cardiovascular medicine where rather than opening up the chest, which, by the way, is the first intuitive sort of application with Fred Moll. We used to do that for basically doing valve surgery and doing coronary surgery. Today, we put the valves in through the groin. There's no mediastenotomies. There's just a small little hole in the groin. It's a multi-eclectic orientation with imaging people, with surgeons, with interventional cardiologists. And in this woman, who's an 82-year-old who could barely walk 3 weeks ago, who has got an aortic valve area of 0.6, barely getting enough blood to her middle cerebral artery, in 32 minutes gets a new valve, and rather than staying in the hospital 7.2 days on average for heart surgery, she's out in 72 hours. This is revolutionary, a change in how we think about patients coming to the hospital, being in the hospital, and get discharged from the hospital. Being able to take complex surgical procedures and move them into, say, an outpatient setting. And you say, well, how can that happen? Well, everybody knows what a rotator cuff tear is, right? Rotator cuff tear occurs in the young, and it occurs in the elder. 1 million cases annually just in this country. It's a 3-hour surgery. This is an 11-minute procedure under local as an outpatient. And this is taking a page from cardiology. Remember, in a rotator cuff tear, what happens is the bone is on the bone, and it hurts. You can't lift your arm. You can't snap your bra on. Within 11 minutes, under a local, in the clinic, we put this spacer, if you will, in the subacromial space, to immediately have that bone off of bone, that pain be decreased, and that range of motion be restored. So as we put this pillow in, if you will, which is an inflated, biodegradable polymer, this completely relieves the pain. And rather than having your arm in a sling for 8 weeks, which is the procedure after the 3-hour surgery, they're in a sling for 2 days and they're back at work within a week. This saves money. This helps the patient. This is a technology that's approved, been in thousands of patients. Of course, it's going to take about 10 years to get it approved in the United States, but people in China, people in Russia, people in South America, people in Europe are appreciating this procedure today. Let's talk about another movement that's happening in medicine. There used to be the Fistula First initiative about 10 years ago. That means do not put in grafts for hemodialysis. Try to put and anastomose the vessels together. Today, there's a peritoneal dialysis, a PD first. Get those dialysis patients at home, dialyzing themselves nightly rather than coming to the clinics 3 times a week. The problem is that they get infected because the people at home themselves don't follow good sterile techniques. And if you get your omentum infected more than 2 or 3 times, that's not a route anymore. You have to get converted to hemodialysis. So we can take a page out of how everybody, I don't have a hot tub, but some probably out there do, especially in this part of the world. This is how you sterilize your hot tub. You do it with UV light. This is how you sterilize public toilets on the right-hand side, with UV light. Today, with LED technology, we can make this sort of UV light for about a nickel. So here's how you do home dialysis. You connect yourself up. You should be wearing gloves. And you, at midnight when you come home after drinking, you hopefully don't lick your fingers before you stick your dialysis system together. This is a small little device about the size of a thumb drive that has LEDs in it that emit UV light. You simply snap this in series, and therefore all the connectors and all the dialysate fluid are sterilized as it goes in case you've not done it appropriately. This costs $3. And this is an important thing daily to use to try to keep these patients in PD. Again, cost-effective and clinically effective. Simple technology, but going after a big market that is clinically and cost-effective. That's where technologies need to answer the question that was asked a couple times on the mic: where is the clinical resolution of these technologies? So let's talk about a couple others. Talk about the variability of care, something Catherine addressed very nicely. Robotic control, I'm just going to spend a minute on that. And then handheld devices, which I'm going to spend a little bit of time on because it's going to be revolutionary in healthcare. So this is how we practice medicine. When you're in Lubbock, Texas, you get a different cardiology opinion than you do in Lincoln, Illinois. And as a result, you get a different procedure. It might be an operation, it might be putting a stent in through your groin. But the variability we have from diagnosis all the way to inventory in this country is huge. You can get a knee operation in one part of Fort Worth for $2,000, and it costs $40,000 on the other side. You can get a colonoscopy in New York City for a bargain of $720, but in Manhattan it costs almost $7,000. That variability confuses the patients, the payers, the providers, and us physicians. We're not really good at math, so we probably don't notice it. But it's incredible with respect to this country. So what we need to do, you all heard of receiver-operator curves. This is doctor-operator curves. We need to decrease that coefficient of variation. We need to do it upstream with things like biomarkers and cells, a little bit that Catherine touched upon. We need to make sure that upstream, midstream, and downstream being inventory are narrower and narrower. In other words, we need to increase the a priori probability of subsequent tests so that the predictive value of that test goes up, and therefore the variability goes down. So let's talk about something way upstream. This is my cells taken from my skin and taken from my blood on 4/29/13, just a few months ago, and in 10 days later, through a programmable cell technology, which has basically won the Nobel Prize. This is up at the Gladstone Institute, Professor Yamanaka. My cells got dedifferentiated, then they got grown up in a dish as my cardiac cells. Those are my beating cells. Now, what's important is if I ever go into heart failure, I know exactly what drugs work best for my heart failure. That's a much better way to treat than what I do today. I give you a spectrum of drugs, and I see which one works, and I see which one gives you side effects. And we dance for a year or so. This, I can tell you exactly what drug works well for my cells. That's upstream in terms of how to plan personalized medicine. Today, we're getting pretty good at images. That's what I do on the left. That's the angiogram. That's what the radiologists do on the right. Geez, they can almost get the same exact thing that I do by poking holes in your groin and shooting dye in your coronaries as an outpatient. The one problem with that is that on the right, sometimes there's ambiguity seen anatomically, and you don't know whether it's physiologically important. Today, with algorithms, primarily computational flow algorithms, instantaneous calculations of pressure and velocity within those blood vessels, we can actually get the anatomy that you get from the CT shown here of the coronary arteries, but you can get on top of that physiology. It's like the company called Waze. It came from Israel that Google bought in June for $1 billion. It's where all the cars go. They put that on top of Google Maps. This is physiology put on top of that anatomical defect right there. And as I run my finger through that vessel, I can see where the problem is. And then what I do, virtually now, remember the patient hasn't even seen the cath lab yet, I put in a stent. I put in a 33 millimeter stent, and then I rerun the algorithms and make sure that when the patient does come to the cath lab, I've got the right stent for inventory control, and I've predicted what that patient's going to get. I've decreased the variation of what's going to happen to that patient, saving money and being more effective for the patient. So when the patient comes, just like they do for a routine colonoscopy, I've already chosen the stent and the equipment that I'm going to use for them. So again, that downstream inventory control is almost Amazon-like. Cost and clinical synchrony is what has to be the mantra of introducing any new technology into medicine. So in the San Francisco Bay Area, if you drive around 280, you see the Google car all the time. Nobody's driving it. It can't get in an accident. You want this Google car picking up your kids. You know why? Because it will not only identify that they're your kids when they get in the car, but it won't be on the phone ordering a pizza or texting. It'll pick up your kids and take them home. And this sort of automaticity, we have Cadillacs that now parallel park. This is getting much, much closer, as Catherine says, to medicine. This is going to improve medicine. Today, and Catherine didn't show this, this is the robot we use in the cath lab. We sit down, and with haptics, we drive the wires, we drive the balloons, we drive the stents, all independently. I don't get radiated. We use less contrast for the patients. And it's very predictable. It makes that guy and me and 4 other cardiologists in this room do the same thing the same way. With structural heart disease, the confluence of images and haptology. And guess who's good at haptics? It's the 30 and the 35-year-olds, not the 60-year-olds. They still have flip tops and they're using BlackBerry. It's the smartphone folks that have been gamed to death that really have phenomenal control. Whether you're putting a valve in the heart or whether you're putting a small little wire that you see on the right-hand side up into the brain to remove the thrombus for that patient that had a stroke. Precision, 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 but mostly standardization of the practice. So what you've seen is we've decreased the coefficient of variation on how you diagnose patients, how you do the procedure in the patients, and how you control inventory, which is almost Amazon-like. Along the chain of command there, the a priori probability has gone up, and therefore the predictive value of every subsequent test goes up, and most importantly, the variation goes down. So let's spend another 5 minutes on what I think is going to be very revolutionary in medicine. And I see the movement, not necessarily from the Johnson & Johnsons and the Medtronic. I see it from the Ciscos, the Googles, the Nikes, the Samsungs, the Sony, the Qualcomms. All those are moving very quickly into not only personal fitness. We have all our little things on, right? I've got my Samsung watch on. I've got my new smart Fitbit on. 45,000 healthcare apps and growing, and it's actually outpacing Moore's Law, which is actually interesting. But lifestyle, personal fitness is merging into chronic disease management, whether it's heart failure or whether it's diabetes. Patients are now taking control of brokering their own care, not just the exchanges that they're signing up with, but they're brokering their own care. 1/5 of the CES, the Consumer Electronics Show last year, was devoted to healthcare. It's supposed to be 1/3 this year in Las Vegas. So it's very interesting to see that landscape being rototilled by the IT folks. And as we said in the beginning, it's a real IT infrastructure. It's got revenues, and it needs portfolio differentiation, and one of those is going to be into healthcare. The patients, the physicians, the practices, the payers, the 4 Ps can be brought together by the conduits that the consumers are used to seeing, whether it's their iPad or whether it's their television. We all have I happen to be the healthcare consultant for Samsung, so I've got my fancy watch on here, and of course it doesn't go on unless it recognizes my face. But if I touch that watch, and it doesn't matter whether it's an iOS platform, but if I touch the watch here, let's see if I can get it working and see if I don't. So there I have my electrocardiogram live, and I worked out this morning, so that's why my heart rate's a little low. But those are the issues that we have to deal with in these sensors. And the sensors are abundant. There's a gazillion sensors. I see them from Shanghai all the way to Haifa. There's 1 million sensors. It's not necessarily the sensor that's important. It's the cumulative parameters that are being tracked using the patient as their own control. But there are amazing sensors out there. There's buttons, there's shirts, there's tattoos. All this data goes to the cloud. We're going to think differently about how we not only monitor ourselves from a fitness standpoint, but as we enter into a disease state and maybe are more active at preventing those diseases from happening. So we talked about Medicare readmissions rate, 26%. Improving compliance is a huge one. The medications that I or Daniel or some of the docs in the room prescribe to a patient today are not being taken 6 months from now. There's ways to fix that. Heart failure, one of the biggest travesties we have, certainly in North America. 50% of the patients are readmitted within 6 months. 40% of it is due to compliance. So smart patches, communicating lots of parameters, not just the EKG, but the plasmographic signals, skin temperature, blood pressure, a number of these parameters. And I'm not sure I care what the parameters are because they all go into trend analysis, which is what's important. So for this lady, I'm only going to pick 3 parameters: cardiac output, heart rate variability, and respiratory rate, but there's N parameters for that lady followed over time. What I'm really worried about, just like credit card folks are, is when they begin to deviate from their own profile. Not George's profile, but her profile. And when I know that from a central dispatch, I correct it by changing the medications, changing their diet. And I do that from a distance, rather than waiting for them to come in and crash in the emergency room and make up that whole cycle that we're not very good at retarding today. So big data, we hear about it all the time, we read about it almost every day. The predictalytics, which is the fused word, if you will, between predictive and analytics. You know what BIG stands for? Being intrusive gradually. Now, we all know that our buying habits are tracked, and you folks all probably read this in the New York Times the other day. A dad gets a letter, he's 58 years old, and it says, hey, you got a new addition to your family. His 57-year-old wife's tubes were tied a decade ago. He's kind of irritated, so he goes to Target and says, hey, come on. And he got irritated so much that he filed a lawsuit. Well, 13 days later, he goes back and he apologizes because he says, my daughter's pregnant. Now, how did Target know before her dad? Not because she bought an early pregnancy test, because that particular age, that particular ethnicity, that particular region, geographically, if she starts to buy different types of lotions within a different period of time, there's a 99.2% chance she's pregnant. So think about that on the back end. You know how that sign on the airlines goes on, the seatbelt sign, and you're kind of irritated because you have to go to the bathroom and the plane's not wiggling? All that's predictalytics from the many, many times that those four-dimensional sensors have gone between San Francisco and Toronto last year and this year. So they can predict what it is. Let's go back to our CHF example. This lady, we need to follow her trends. When she begins to get into that red zone, we need to be alerted. This is an example of a predictive algorithm, one that was used to predict jet engine failures, by the way, that showed that 6 days prior to her hospitalization, she was entering that red zone. This predictalytics on the back end of how to manage patients remotely is going to be one of the most prolific, dense, if you will, into the healthcare continuum. We see tattoos that are sensors. We see little babies that can get all sorts of information from them. Again, it's not necessarily the sensors, it's what you do with it. And I want everybody to think of something here. 5 years ago, we didn't have smartphones. You don't need to invent for today, you need to invent for what you think is going to happen tomorrow. You need to look at this curve and think there. For example, we talk about the public cloud and we talk about the FDA scrutiny. Suppose in your hands, that most of you guys are looking at, by the way, suppose in your hands you had 2 terabytes, you had 50 gig of RAM, you had a 6G network, I don't even know what that is, you had 50 megapixel camera for whatever you need that for, but suppose you had personal clouds and could manage your own data, and you will be able to manage data as long as it doesn't go to the public clouds. Be thinking about that in 3 years, because that's what we're going to be, and the people that are going to be the new market for healthcare are the folks that have been used to that. They don't mind giving up a little exposure and privacy for convenience and efficiency. We see that in our young with Facebook. So this is really going to have a disruptive part of healthcare. And I'll just use one more example and then I'll shut up. We give our poor elderly, when they're over 80, an average of 11 drugs. They can't see them. They can't remember what color to take. We have smart pills that have transistors in them. We have smart pill boxes. We have activity alerts. Here's an interesting medical management, PALM-based system that not only with your camera records all the pills that you're taking, but alerts you to the color when you should take it. It also gives you information about what might be complications with respect to your diet or another pill that another subspecialist gave you because you had a foot problem. But it also echoes in your social, like your family. So for parents, with respect to the 17-year-old that's taking an antipsychotic drug, they'd like to know whether she or he is not taking it. So when you start looking at this, and this is real data, because this site just went up 6 months ago, and begin to look at the population that's utilizing this, and I can peer into Boston, and I can see what the adherence rate of a 17-year-old and her antipsychotic drugs are, and I can also look at what it is in Sao Paulo or Barcelona. You begin to learn online what the habits are, what the predictive power could be, and how you could help manage medicine in this continuum of chronic disease. That'll be applicable for epidemiology, drug trials, and personal care. So in conclusion, MedTech will continue. I've not witnessed such an innovative stripe globally, though. It's not all in the Bay Area. The need is the most important ingredient for medicine, just like Catherine's taught us. But the process, cost and risk sharing will be king and the new ingredient for healthcare. Reducing healthcare variability is our number one focus, from diagnosis to therapy to inventory. And IT will play a major role with respect to medical technology and biotechnology going forward. And not only the 4 Ps will be facilitated and made more efficient, but patient care will be improved. And that's, I think, what the mantra of Future Med is. Thank you for your attention.